All right, good afternoon, everyone. This is Jason Crosby of Strategic Healthcare Partners. I want to thank you for joining us today. We'll cover the recently released QPP proposed rule for 2023. But first, a couple of housekeeping items before we get started. Everyone is muted until the very end of the call. So if you have any questions during the discussion, feel free to use the chat box on the right-hand side, and we'll be sure it gets addressed. And later on today, you'll also find the presentation along with the recording of the webinar uploaded to our website for your access. So let's go ahead and get jump started. Today's focus, as we mentioned, will be related to all things quality payment programs, QPP, with some brief recap to get us all up to speed, and then an overview of the proposed rule. Today's presenter is Aaron Higgins, who has been with SHP for a few years now in our analytics department and as our IT strategist. After about 10 years or so with various private practices, focused primarily on quality programs. So with that, Aaron, let's get us started.
Alrighty, thank you, Jason, and thank you everybody for joining us today. So we're going to cover, as we said, everything QPP. So the quality payment program every year is changed, and every summer CMS drops a new proposed rule, and then they finalize that rule usually right around Thanksgiving, sometimes as early as Halloween, but usually it falls around Thanksgiving, and I end up spending Thanksgiving weekend reading through it. So let's jump right in. Again, I want to stress this is the proposed rule. Every time this comes out, they will release a final rule, and there may be things in the final rule that weren't even discussed in the proposed rule. So it's important to know what's being proposed so you can start to adjust your plans, but don't put those plans into cement quite yet. So let's talk through the minor tweaks and changes. There's actually a lot more bigger changes this time around than minor ones. Last year, due to the pandemic, CMS really didn't want to do a whole lot of substantive changes to the various categories. So there's a whole lot more tweaks. This time around, there's not a whole lot of tweaks. There's some more substantive changes. So really the two minor tweaks, I couldn't fit into any of the categories, are APMs. They're going to allow APM. So what is an APM? That's an alternative payment model. Those are ACOs, those sort of things. You can now report promoting interoperability at the whole level. So previously PI had to be reported individually by practices or individual eligible providers. What CMS is proposing is that the APM can do it for everybody on the APM level. This could be a really big change, particularly for the very large ACOs that are out there. Another change too is they're proposing giving the complex patient bonus. That's an additional 5 points to your base score, even if you're not able to complete all of the categories. So this could be really big for smaller practices that deal with a lot of complex patients. Okay, so let's jump into the big changes. Scoring changes are definitely, yes, sir.
Back on that last one, what are you about to drive into details of those changes? Like if we don't submit all our data, what specific data or any of those, you're going to hit those details?
Yeah, we'll definitely hit on what those details are, data completeness, and what sort of categories, if you can't or won't submit those, maybe you're not happy with the score that you're getting there, and it might be better to not submit data at all.
Got it.
So let's talk about scoring changes. This is kind of the big one, happens every year. Due to the macro law, which was signed in 2015, there are certain thresholds that had to be hit based off of what category it is. So starting in 2022 and going forward into 2023, the 4 different categories were set to quality at 30, cost at 30, promoting interoperability at 25, and improvement activities at 15%. Cumulative, obviously, that reaches the total score that you'll need across all 4 categories. The performance threshold is currently staying the same at 75. This was a surprise in this proposal because last year they were wanting to get very aggressive in the penalty avoidance. So that's going to stay at 75. But the big one is that exceptional performance will end at the end of this year. So presently, off the top of my head, I want to say it's 85 points or higher gets you additional monies. That goes away. So if you're scoring really well, you'll still potentially get more in your bonus, but you're not going to get the bonus to the bonus. Another change too, and this was finalized last year in reporting year for reporting year 2022, which is this year, is small practices. So the small practice weights are going to be quality at 40, cost at 30, and improvement activities at 30%. You're asking, well, what happened to promoting interoperability? CMS proposed last year that small practices don't have to submit promoting interoperability for at least the next 3 years. And they're all automatically going to weigh that to 0. So again, you don't have to submit promoting interoperability if you're a small practice.
And Aaron, what's the definition of a small practice?
A small practice is going to be any clinic that has 15 or fewer eligible providers. Odds are most of the folks here on this call are a small practice. That being said, if you are submitting promoting interoperability and you're doing a good job at it, keep doing it. There is no penalty for continuing to submit PI, and they're only saying they're going to do this re-rate for a few years. So again, if you're 15 or fewer clinicians and promoting interoperability is something you're struggling with, or you don't want to do it, you probably don't have to do it for the next couple of years. Just be aware, don't undo things you've done to complete PI, because it's going to come back and then you're going to have to put all those things into place. Good question, Mike. Okay, so the weights, just a nice little visual representation of what that is for you. And then the performance threshold. So right now, if you are scoring less than 75 points, you're going to get penalized. And what that penalty is the closer you are to 75 points, the smaller the penalty is, and the further you are from it, the greater it is. If you are at 18.75 points or less, all the way down to 0 points. So if you don't submit at all, you will get a 9% haircut across the board to all of your Part B payments. So just be aware of that. You'll want to submit even if you're not hitting 75 points to avoid that haircut. Now, if you are scoring above 75 points, so 75.01 points or greater, all the way to 100, you'll receive an up to 9% adjustment on your Part B payments. I've never met anybody who has actually gotten that 9% because the money actually comes from those that are getting penalized. So that's why it was kind of a surprise why CMS is not proposing moving that goal line to a higher threshold. I suspect we may actually see that in the final rule, because they talk about it a little bit about why they decided to not adjust it, because they were going to adjust it to 80 points. But we'll see. I think they may adjust it. Okay, so here's a visual representation of the small practice weight changes. So if you take the automatic reweight for promoting interoperability, the pie chart on the left is going to be what comprises your goals to achieve. But small practices can also do a hardship penalty, a hardship reweight request. Boy, that's hard to say. You can ask CMS, and there's a little application that you go through. And if you qualify, you can have your cost category re-rated to 0 as well. And in that case, 50% of your score will come from quality measures and 50% will come from improvement activities. Again, unless you've done historically bad on your cost category, which, to be honest, is really hard to tell until after the reporting year is done, because you don't know what your score is throughout the year. There's no easy way to find that out. So if you look back at your last couple of years when cost has been a thing, and if you've been performing poorly there, you can ask CMS, hey, reweight that to 0, and you can just take the improvement activities and quality, you just want to do really, really well on those. So bear that in mind. That is an option out there. There's an application process. We'd be more than happy to help walk you through that process, but it's a simple form.
So, Aaron, what do you think most people should do? Is it that they take the reweight? Is it easier, or what? What do you think most small practices that are paying attention to this? What do you think they will do?
Yeah, that's a really good question. So promoting interoperability used to be meaningful use. So if you were all in on meaningful use, you've already implemented everything and you have all the connections, you're already submitting your registries, you're already doing everything and you're doing it well, don't take the reweight, because 2 or 3 years from now, when CMS has indicated that they're going to end the reweight, you're going to be caught unawares. Maybe you've turned off interfaces, or maybe you've stopped paying the bills on a registry, and it may cost you additional money to start that back up again. With the cost, that one's actually more tempting because in order to see your cost insights, you need a tool to do it, like a population health tool. And if you don't have a pop health tool, the only way to find out your cost score is after it's already set in stone and it's too late to change anything. So if you've performed poorly in your cost category in prior years, so you have the last couple of years of performance to go on, and do the hardship exemption. Just say, like, look, we're a small practice. We want to be exempted from cost. CMS has not given any indication of how long the cost exemption is going to be. Which says to me that they plan that for the long term. So if I had to make a choice and I was picking between the two of them, I would take the reweight on the cost if I'm not doing well. But again, if you're doing well on all of these, great, continue to do that. I would shy away from doing the auto reweight on the promoting interoperability, unless you're just doing absolutely poorly.
Got it. Thank you.
With the auto reweight, these clinician types are newly eligible or were made newly eligible recently. And CMS knows that these particular clinician types don't really do a lot with patient portals or electronic sending of prescriptions or things like that. So they have and will automatically exempt, even if you're reporting as a group, these folks. So these folks' performance in promoting interoperability won't count against you as long as you're not submitting their information. So if for example, you have an NP in your practice and their performance in PI is miserable, just exempt their data from the rest of the group. You're allowed to do that. That's what this says. Okay, let's jump over into the quality category changes. The administrative claims measures, most of you are probably not doing these, but these are the measures that CMS pulls out of claims automatically for you. You don't have to do anything. They're changing the way that they're scoring those. So previously they would, well, proposing, I guess is the word to say, proposing the way to score those. Essentially what they are proposing to do is look at all administrative claim measures for the same year that they're being reported. Instead of looking historically back, they're saying, okay, we'll pull the measures for you automatically from your claims and then score them accordingly. This happens automatically, and CMS will take those scores and look at what you submit. So if you submit 6 quality scores, and let's say you score 80% on all of those, but they've pulled 6 from claims and you've scored 90% on those, they're going to use those administrative claims versus the one you've submitted. They do that automatically. There's nothing you need to do about it. They're just cleaning up some of the way that they're handling the scoring. Data completeness needs to be 75% for 2024 and 2025 and 70% for 2023.
And how do you define data completeness?
Yeah, so data completeness is going to be the number of patients or the percentage of patients reported. So for example, in this case, in 2023, 70% of patients seen need to have their data collected and reported. Hopefully it's higher than that, but depending on some EHRs and the way that you submit your data to CMS, they're only asking for 70% of your patient volume in 2023, and then bumping that up elsewhere for future years.
Got it.
And then the high priority measures. So in the quality category, the high priority measures are given a little extra weight, and you have to submit at least 2 of those in your total of 6 measures that you're submitting. They've created a new category called health equity related measures, and we'll cover what those are. Those are in the proposed new measures. And I'm not going to read through all of these. Feel free to screenshot or download the slide deck when we get it posted to our website. So there's just 9 new proposed measures. This is kind of the smallest grouping that we've seen. They're going to propose to remove these measures. It's not as much as last year. Last year we had 19, and here we have only about a dozen. But they have topped out, limited, duplicative. So they feel like there's another measure elsewhere that does the same thing that they're trying to accomplish in this measure. And then there was one that they felt does not improve care at all. In fact, could actually harm care, so they're removing it. And then 2 more, 110 and 111, they're going to move to the MVPs, and we'll get into MVPs here at the end.
So what's topped out and limited? What do those mean? Like it had a limited impact, or it's topped out the impact it can have?
Yeah, exactly right. So topped out means everyone was doing it, and so they feel like this is so commonplace that there's no real clinical benefit to scoring it anymore if everyone's doing it. I have mixed feelings about that. I feel like, well, I think the reason why everybody's doing it is because it is something that should be done, but maybe we should continue to keep an eye on it, but whatever. And limited means almost nobody was doing it, or it was such a limited audience of patients that it was too much of a struggle to try to even get to that threshold of 20 patients seen.
Got it.
Now, they are proposing to change 75 quality measures. I didn't type them all out per se. They're all there. So the dashes, so like 116 through 118, et cetera. You can figure it out from there. But I want to call out 2 of them, and that's 130 and 226. So 130 is medication reconciliation. They're changing that to be any and all OTC medications. That's vitamins and supplements and medical marijuana. So if they're going into a dispensary or a pharmacy or Walmart, and they're taking a baby aspirin once a day or something like that, they want that to be documented. So that's a new requirement. And 226 is the tobacco screening. They're broadening that to be any tobacco as well as vape products. So nicotine gels included, snuff, chewing tobacco, e-cigarettes, the whole 9 yards. That's big. You want to make sure your EHR supports the capture of that data, because 226, I feel a lot on this phone call, do that one, because it's important. 5 new measures in the cost category. Cost category measures you can't pick. They're picked for you if you do them. So again, there's not a whole lot of insight to this. Once you've done it, you've done it, and then CMS will tell you afterwards, about a year later, how well you did. Improvement activities. 4 new improvement activities are proposed. This kind of falls in line with their whole wanting to include health equity measures that they announced last year. This is just kind of the trickle down of that. The last one is COVID-19 vaccine achievement for practice staff. What that one is having everybody on your staff vaccinated or boosted for COVID-19. The goal for that one is 100%. I didn't see any exemptions for that. I don't know if your practice had any kind of COVID-19 vaccine campaign internally. Just be aware that that one has to be 100% in order to be an improvement activity that is achieved. Some proposed changes to improvement activities worth a read through on if you use any of these. All of these page numbers are referenced in the proposed rule. And again, we'll include the proposed rule in the upload to the website. So you can go there and you can say, oh, well, I'm doing use of QCDR data for ongoing practice assessment. And you can go read what's proposed to be changed. And then they're going to remove these 6. 5 of the 6, the first 5 there, they felt they were duplicative of other activities that already existed, so they didn't feel they were necessary. And then the last one, the PCI bleeding campaign, well, the PCI bleeding campaign ended in 2021, so it was an oversight. They should have removed it for this year, and they didn't. So if you are partaking in this improvement activity, be aware you can't, not even this year. So they're actually proposing removing it retroactively. Okay, promoting interoperability changes. Some big changes happened here. And again, going back to the small practice, if you want to take that exemption, you can. The big one is the PDMP. So the state of Georgia does require anybody who prescribes controlled substances look at the PDMP. Some EHRs bake that right in. Others, you have to go to a website to do it. So if you are in the state of Georgia and you're not checking the PDMP, be aware there is a legal requirement for that. But CMS is now incorporating it into the promoting interoperability as a required measure. Previously, it was an optional measure. They feel very strongly that this needs to be required. They're also going to include Schedule 3 and Schedule 4 opioids in that, not just the Schedule 2 drugs. So be mindful of that. If you are scripting those medications, your EHR needs to support the documentation that you went to the PDMP in some fashion. They're creating a third option for the HIE objective, and that's if you are participating in the Trusted Exchange Framework and Common Agreement. That's a question for your EHR vendor. You don't need to answer that question necessarily right here. If you don't know what TEFCA is, talk to your EHR vendor. They'll be able to tell you if your EHR is a participant in that. And then there's some score changes within the measures themselves. E-prescribing stays the same at 10. PDMP is no longer a bonus, it's now required. HIE changes, so it used to be worth 40 points and still is for reporting year 2022, but they're proposing changing it to 30 points. And then there's some sub breakdowns within the measure itself of how to actually participate with an HIE. And so you have to do all of these subpoints. So, 30 points here for a bidirectional HIE, or you can do supported electronic referral loops. You don't have to do all of these 3 subpoints. Provide patients their access to electronic health information, which is worth 25 points proposed versus the 40, so on and so on. I won't read the slide to you. And then require the level of participation. So this is a change. Right now, it's do you or don't you? It's a yes or no. Now they want to know, are you? And then what level of participation are you? So it's no longer this binary, are you doing it? They're assuming that you are. And if you aren't, you can't answer the question, and then you would fail that measure. Instead, they want to know if you're in pre-production and in the validation stages, or are you actually in production right now with your HIE? And they're going to also make the same change to the public health and clinical data exchange measures. Okay, so pivoting away from traditional MIPS, we're going to get into MVPs. This is the next generation, so to speak, sans Patrick Stewart. CMS felt that MIPS was too broad as it is, very confusing to the uninitiated, where to begin, what measures to select, that sort of thing. So they introduced MVPs in 2020. And they said that this is where it's going, this is where we want it to go. So think of MVPs as the evolution of MIPS. So in a nutshell, it's a pre-assembled list of quality measures, improvement activities, and cost measures that are relevant to your specialty type or the type of care that you give. Not necessarily your taxonomy, but what sort of care you're actually practicing. You will only be compared against other clinicians in the same MVP type as you are in. And between 2023 and 2026, so those 2 years, really 3 years, it's voluntary to participate in an MVP. But once you're in, you're in. You can't exit the MVP once you get into it. Now they've reworked some things. So initially when they were first announced, it was all about taxonomy. And then last year they said, ooh, maybe that's a bad idea. Let's maybe focus on something else. And they answered what that something else was this year. And instead it's going to be more on what type of care you're providing. So whatever your taxonomy says almost doesn't matter. That can be a starting point. Now it's going to be what sort of patients are you billing and what sort of conditions are you treating. And with that, they've updated the name of the 7 existing MVPs they previously created. And they're also proposing 5 more to be added to the stable for 2023. So we're going to have potentially a total of 12 MVPs available to participate in voluntarily next year. So the first 7 are here on the left column, and on the right we have the new 5. Okay, so let's talk about participation. Again, optional right now. In the future, it'll be mandatory. So the way that it'll work is that you'll have 4 quality measures that will be a smaller menu for you to pick from when you participate in the MVP. So instead of 6 that you need to do now, you'll have 4. Then you'll have your improvement activities, and you can pick 2 medium weighted or 1 highly weighted, or if you participate in a patient-centered medical home, a PCMH. And then each MVP will have their own cost measures, and then 1 population health measure, which is a improvement activity or quality measure that's also tagged as a pop health measure. And then, your base promoting interoperability. Now, one of the little things that hasn't quite been answered is if you're a small practice, do you still have to do the promoting interoperability? Is that still weighted to 0? I haven't seen an answer to that question yet.
Darren, I don't know when you're going to, when you're out of the detail of this, but I guess my general question is, to make this practical for us, like, should folks be reacting to this now, or is this something that is coming in the future, and this is more FYI? Can you drop that down into kind of what we ought to be doing concrete, or you're about to get there?
Just about to get there, 2 slides from now.
Okay, thank you.
So the MVPs will work between April 1st and November 30th of the reporting year that you're in. So let's say next year you decide, hey, this sounds great. Smaller menu. I don't have a whole buffet to pick from. I got 3 items to pick from. Great. So you want to participate in MVP. Enrollment will be available to you between April 1st and November 30th, unless you're doing CAPS. If you do CAPS, your deadline is June 30th. So it's a smaller window if you do the CAPS surveys. For 2023, 2024, and 2025, individual clinicians, single specialty groups, multi-specialty groups, subgroups, and APM entities can report as an MVP. After 2026, when it becomes mandatory, that's going to change. An MVP, in the MVPs, multi-specialty groups won't be able to register as 1 MVP anymore. So if you're a multi-specialty group now, you want to do an MVP, you can pick one of the 12 MVPs available. But one of the things they're introducing over the next couple of years is what they're calling subsets or subgroups. And multi-specialty groups, because there's so many different types of practice within there, they want you to be as granular as possible. So just be aware that if you're multi-specialty now, you can pick an MVP and everyone can participate and get the benefits of the MVP. But come 2026, you're going to have to get a little more granular. But there is some benefits to doing an MVP now. So what they're saying with MVPs is the pros is that there's a less administrative burden than a traditional MIPS. You don't have to sit down every December or November, read through the final rule, pick which measure because your favorite measure is going away. It's topped out or whatever. The MVPs are going to have a much smaller list to pick from, and they're going to be tinkered with less. According to the narrative from CMS, once an MVP measure is set, unless there's some kind of extreme thing that happens, they're going to be permanently set. So that's good to know. So the picking process is less daunting. You can go in, you have 8 measures to pick from, you only need to pick 4 instead of a list of 199. That means there's going to be fewer measures for you to track. That's less training for you to have to do with your staff and less worries if your EMR actually supports this. That should make the scoring easier to understand, at least according to CMS. So there are some cons, particularly if you've been doing traditional MIPS for a long time. This may be confusing. You may have liked having all of those menu options. Well, those are going away. You also need to be cognizant and aware of what measures you're going to be doing, and you won't be able to register until April 1st. So heading into that time period, what happens to the first 3 months of time, because they're still looking at the full year for your measures. So you need to have a little bit of pre-planning ahead. Your EHR needs to support all the measures that you want to do. So you'll need to check ahead with your EHR vendor before April 1st, before registration opens. And then you may need to retrain some of your staff because some of the measures that you're doing now may be ones that you can't do if you're a part of an MVP. And as far as should your practice do it, honestly, let's have a conversation and we can kind of talk through some of the pros and cons within your own organization. If you feel like taking some of the administrative burden off sounds great, then let's look at it. They do have MVP toolkits. CMS has these toolkits, and I was looking through them. They're very exhaustive. They're well written. They're easy to understand. Go figure, something created by the government, easy to understand. You can go and look at the current 7. So the 7 that were finalized in the 2022 final rule. I'm sure they'll be adding the 5 that they're proposing as soon as the final rule is dropped. But if it sounds interesting to you, you want to learn more about the existing 7 toolkits or 7 MVP types, you can download the toolkit at the resource library. Just search for the word toolkits and you'll get 7 results, and those are the 7 results. Okay, so we're wrapping up here. What do you need to do next? Well, I'm going to, it says shared in chat. I'm going to just put it on the website instead of cluttering our chat up with a link. Go to shpllc.com/webinars and you'll be able to download the resource packet there. You'll have this slide deck. You'll have the documents from CMS, as well as links to the resource library on CMS's website to look at those toolkits. And if you're really not sure, you want to have another conversation, maybe a deeper talk about are MVPs right for your organization to do now, or should you wait? Shoot me an email. I'm available to answer any questions that you might have. Be happy to talk to you too over the phone. Talk to your client rep if you have one. Be more than happy to set up a meeting. The official resources can be found at qpp.cms.gov. If you go to the About button up there in the upper right corner, you can get a link to the resource library, or you can call the QPP help desk. Honestly, when I don't know the answer, that's who I call, and they are always extremely helpful. Alrighty, well, I think that wraps it up. Are there any questions? Anybody want to know more about a topic to do with QPP? Anything I didn't answer? No,
I don't see any
already.
in the chat. If anybody has anything, there's the chat button either at the top or on the right of your screen if you want to post anything. All right, nothing there. All right, well, thanks, Aaron. That was a lot to digest for sure. A great topic, very relative to the time frame. Again, everybody, please look for today's presentation along with the recording. We'll have it uploaded to our website on the webinars page that you'll see at the top there, probably later on today at the latest tomorrow. And as always, feel free to reach out to anybody at SHP with any questions regarding today's topic, and be on the lookout for our next webinar and here in a couple months our upcoming podcast series. And until then, everybody have a great rest of the day and a great week.
Thank you all.
Thanks, y'all.